excited about. Let me just say a few words about our guest speaker, Dr. Leslie Johnson. She's assistant professor in the Department of Family and Preventive Medicine at Emory, and also associate director there of their D43 training program in implementation and team science, a great combination, and also for their non-communicable disease control program called Titans. And if she has a chance, Leslie might want to tell us a little bit about that. I'm intrigued, but I have to confess I don't know about it. She's an implementation scientist, has particular expertise in participatory health research approaches and in applying mixed methods for complex health systems challenges that I know at least I and I think most of us face. Her research focuses particularly on the adaptation and evaluation of integrated chronic care models uh, and testing strategies to enhance adherence to chronic care guidelines. So, with that, I'm going to turn it over to Leslie. Thank you all for participating, and please, as always, use the chat as we go along.
Okay, can everyone see that?
Yes, looks great.
Perfect. All right. Well, thank you so much for having me and for that kind introduction. It's a pleasure to join you all today and share some ongoing work from an implementation effectiveness trial that I was involved with for the last 5 years, the Integrating HIV and Heart Health in South Africa trial, or for brevity, call it the IHEART SA or South Africa trial. So my journey with the study actually started back when I was a postdoc. I was engaged in the grant writing process for this study and was namely focused on that formative phase evaluation work, and was fortunate enough to transition to a co-investigator role as faculty soon after it was funded. So my time today is going to be focused on unpacking that one sentence in the grant that indicated we would be evaluating adaptations of our implementation strategies during the implementation and sustainment phases of the trial. So I don't think I need to stress to this working group that implementation doesn't occur in a vacuum. As such, our implementation strategies, the methods or techniques we use to improve adoption, implementation, and sustainment of those evidence-based interventions rarely unfold as we plan. Our strategies are embedded in dynamic systems, and when those systems shift, the strategy may as well too. And if we don't track those shifts, we put ourselves at risk of potentially misinterpreting either the implementation or the effectiveness outcomes. So I'd just like to take one of the examples from our work, a key strategy that we used in iHeart, the audit and feedback strategy. And this is an evidence-based approach, theoretically grounded in performance improvement science. And our mechanism operated under this assumption that there was a stable underlying leadership structure within the primary care facilities where we were intervening. As you can see by this somewhat generic org chart that I've developed to depict our primary care facilities. And the theory of change proposed that feedback on hypertension screening and treatment would influence behavior through motivational mechanisms, with clinicians using performance data on in order to help self-regulate those target behaviors, which would then subsequently be supported through managerial feedback and acknowledgement to hopefully motivate and sustain those behaviors. So we kind of see this nice little loop occurring where we're giving feedback both at the individual, but also at the leadership level to encourage and sustain behavior. In practice, though, leadership turnover destabilizes this feedback loop, right? So we're kind of dependent on that top structure, and feedback was provided to specific clinic staff and managers, but with high leadership turnover, that meant that that managerial feedback was not as impactful, perhaps, in motivating staff. And in some cases, those managers may not have been invested because they weren't the ones who were there when we initiated the trial, so they didn't have as much buy-in perhaps, or they were in interim positions. So we see that perhaps in worst case scenarios, there might even be gaps in someone taking on that role as a permanent position, and we have someone providing an interim spot. So all of these shifts in leadership here can have unforeseen consequences in terms of how the mechanisms are operating within our audit and feedback system. And with those social support systems not functioning as intended, the question is then, what adaptations, if any, were made to the strategy in light of this, and how can that be best and systematically tracked over time? So to make the most of our time today, I'm sure I could spend an entire hour just telling you a bit about the study. I don't want to go into too much detail about the background of the trial itself, but I think it's important to know some basic aspects. And so I'll walk through some examples, um, more focused on transitioning into our focus on adaptation. So here, I just wanted to note that our process of selecting the implementation strategies for iHeart was guided by the behavior change wheel. And so we had a goal of addressing certain priority provider and patient level capability, opportunity, and motivational barriers to detecting and controlling hypertension among patients with HIV who were receiving care at primary care facilities in Johannesburg. So a specific region, Region F, within the city. So for those who may be less familiar with the behavior change wheel, here in this little diagram, you can see the three different distinct stages that we follow along in this mapping system to select the strategies, and that the COM-B model, or capability, opportunity, and motivation, those key dynamics, serves as the determinants framework at the center or hub of the wheel. And so across the different stages, it provides methodological guidance for selecting the strategies that are responsive to those priority barriers. And we engaged a diverse range, a very wide range scope of stakeholders, community members, health system decision makers, patient advocates, people affected directly and indirectly by these health conditions, both locally and nationally, as well as having a scientific advisory group that would be involved in providing feedback across these various stages through different methods. And so you can read more about that process in a forthcoming paper that I've referenced here at the bottom of the page. But my point being that there was a lot of intentionality behind the selection of these strategies and how they were specified pre-implementation for these settings. And in our protocol paper, the theory of change is laid out with this nice little diagram in accordance to the COM-B model domains. So again, you see those buckets there with capability, motivation, opportunity. To better understand how we thought about adaptation, I think it's helpful, of course, to get into the weeds with at least one example. So let's just continue on with this audit and feedback example. Amongst our formative qualitative feedback that we got from clinicians, we often heard that based on the high volume nature of these facilities we were operating in, clinicians were faced with lots of competing priorities that often resulted in the failure to take a patient's blood pressure. And this was often in co-occurrence with other patient level barriers, of course, people being busy or wanting to skip the vitals lines. But what resulted was a lot of inconsistency and motivation to maintain that sort of behavior, especially as the peer environment may not have facilitated that as well. And so this continued through the kind of patient flow chart, where not only were we failing to then have the BP measurement taken, but then as a result, we wouldn't have counseling or medication initiation during the patient consultation. So based on this issue, as it was described, we considered it motivational because, again, the patients, the clinicians were being pulled into different directions in their clinical responsibilities and are making conscious trade-offs in which responsibilities take precedence over the routine collection of blood pressure measurements. And then we undertook a lot of ranking activities with our community advisory board. And during those ranking exercises with the working groups, this barrier rose to the top of the list in terms of one of the top three barriers that were a priority that we then sought to address when we selected our strategies. So kind of following the behavior change wheel mapping processes, we mapped out those barriers to the corresponding intervention function, which it gives you these lovely little tables that you can map onto. So falling under the persuasion button box there, and then the behavior change technique, or active ingredients, if you will, as how we thought that would function. We wanted to provide that feedback on the outcome of their behavior. And then we worked with our group to then specify what this would look like, or as they refer to it, the mode of delivery. And so kind of having some basic scaffolding as to what that would look like actually applied within this setting. And through those iterative engagement activities, we were able to kind of do this process in a much lengthier and detailed fashion than I'm displaying here, but just to give you a flavor for what that process entailed and how we arrived at this. Although I think it's worth noting that the behavior change wheel was not developed for the purpose of designing implementation strategies. So the language you see here that we're using doesn't always line up with our implementation science language. So I like to think of it as a 2 steps forward, 1 step back approach of translation, where we ended up with mode of delivery according to the behavior change wheel. But in practice, that was actually closely mapped with how you might specify the implementation strategy. So we kind of took it back a step to identify the ERIC language, just so we could have a more cross-cutting language to look across other studies and applications of this strategy. And so at the bottom, you can see the ERIC definition for the audit and provide feedback strategy that we used. And then we took time as a team to then kind of operationalize this using Proctor's specification framework. So really going through and identifying for the study protocol, who would be conducting the behavior, what were they doing, how often were they doing it. And as you can see here for audit and feedback processes, we wanted that to be led by a care coordinator in each facility, who would use information from a data collection system developed for the study to summarize key metrics on hypertension, case detection, and treatment rates, and then present that data to the full clinic team. So including the managers, clinicians, non-clinician staff, with opportunities for programmatic feedback and discussion on how to improve those target behaviors. And this would take place monthly over the implementation period, with the goal of increasing awareness of the provider and clinic level performances, and then hopefully increasing motivation to improve screening and treatment behaviors. So directly linking mechanistically to our goal of increasing implementation fidelity. So those appearing right there. So overall, we wanted to be able to track adaptations of all 5 of our strategies in real time during active implementation to assess how those modifications were affecting adoption and fidelity. I think we might have something in the chat, so I'll pause before we dive into this next section and see if there's any questions.
I was just probing. I don't know, Leslie, about others' experience, but maybe given the time, we should wait for the end. But I'm just guessing this group, not everybody is familiar with the COMBI or behavior change wheel. I do have some questions about it myself. I'm intrigued with it, but I think maybe that one we might want to hold because it could be a longer discussion.
Sure, yeah, we can save some time at the end to unpack that a little bit further. It's definitely just a little snapshot there at a high level of what that process entails. So happy to answer questions at the end that people might have around that. Okay, so we'll continue on then if there's no other questions related to what I've introduced. So for our fidelity or our adaptation tracking, we decided to use the FrameIS tool, which is designed specifically to track modifications in implementation strategies. So it offers this really nice template with both core modules and optional modules. And here you can see many of those core modules covering descriptive aspects of what's to be monitored, what with a number of these kind of checklist boxes indicating what is modified, the type of modification, the goal of that modification, and the level of modification. And it kind of continues to cover 7 total modules. So here are the rest of those from which you can choose, and they provide further details on when the modification took place, whether it was planned, who was involved in the decision to make the change, and then how widespread that change is. So fairly comprehensive. And I think what appealed to our team and why we selected this specifically was because it really nicely covers the who, what, when, where, and why components that you're always wanting to unpack. It has a format that appears to be very efficient in terms of the time it would take to complete, the checkbox style and being able to perhaps easily modify the options if there's something we felt was missing. And it was developed with implementation strategies in mind. So obviously there's the frame tool, and this expansion to specifically cater to implementation strategies made it seem like a clear choice. So we tried to use a more parsimonious version, I would say, of the tool to enhance feasibility, making it a one-page kind of printable form with some minor tweaks across the modules and the language. And so where possible, we inserted questions from some of those other modules that would have taken a whole box and kind of included it into module one's box. So you can see like who participated in decisions to modify instead of a whole box on indicating who was involved, just so that it would be easier to interpret to the person filling it in, and they could list the names and of those individuals or their roles, and we could always kind of backtrack that information. We plugged in some additional study specifics, including examples. So I think the first thing there, the implementation strategy being modified, instead of leaving that open-ended, we just provided a checkbox system for that as well, just to make it easier. Of course, you could have another box that says other if new strategies are added, so they could detail that. But this was kind of our iteration of what we understood at the time. And then, of course, having some kind of review at the onset of selecting the tool, we knew there was some of the content options in module 3 that weren't quite as clear to the team. And so we tried to provide some examples where there was a lack of clarity on what that meant for our purposes. And any of the modules that were a little bit more technical, I would say, and jargony in terms of the implementation language, we chose to remove those just simply because they didn't have as much value add for us in terms of what we were hoping to capture at those time points. And we felt like it was asking a lot of our team to become implementation scientists in many ways to complete the form. So we did a team training on the tool, cover the protocol for completing it, and even did some kind of small test runs with some case examples to ensure the comprehension and completeness when filling out the form. But in practice, over the actual trial, we found that there was a number of kind of unanticipated challenges, some of which I guess we might have foreseen, but we did not kind of practice those in that initial training session. So since this was an iterative data collection process, there was not a standard interpretation of whether the form was actually to be filled out based on, what is the baseline for filling out the form effectively? Are we thinking about any changes looking back at what was in that protocol for what we thought we would do according to the proctor specification, or is this based on the last time someone completed this form and what we were doing at that time? So there was going to be more than one point in which we were collecting data and tracking. And so it wasn't quite clear, I guess, for some people, what was the standard of which we were measuring future subsequent forms on. So that's just kind of a point of clarity that we had to debrief. And then if you're tracking, of course, more than one strategy at a time, it can be quite complicated, at least in a printed version. If you check all of the boxes and we have some changes that are noted for more than one strategy, it's unclear as to what boxes are then checked in other modules in relation to which strategy. So I think it became very evident quickly that if you have more than one strategy, then you have to have multiple forms and fill out a form for each strategy, because unless you have some lovely highlighters on hand or some way to shorthand notate which boxes correspond to which strategy, it gets a little complicated to interpret and complete the forms. And while we did keep the reasons for modifications and who was involved in that decision as data to be collected, it wasn't always clear what form of data was driving the decision. And so I think there was some additional information we could have asked for in this module 1 to help have clarity in ways in which we're interpreting the modification data. And then, of course, when you're doing the trainings, a lot of these definitions seem pretty straightforward, and we had a few that they didn't. So we added explanations or added examples, but in practice, it wasn't always as clear, even the ones that we thought were. So in essence, someone might say, okay, well, a session was lengthened and shortened. Does that automatically mean it was tailored and tweaked? Is that like a subcategory? If we do any changes, everything's tailored, so where do you draw the boundary of one versus the other? Um, Things like that, where it just was a little bit ambiguous. And it turned out when we embedded this one pager process into the trial workflows, it was a little bit more burdensome than we had hoped. And given some other contextual complications that I'll get into in a moment, it didn't quite play out as we had planned. So while it was our intention to have this ongoing data capture process during the active implementation in which we could actually analyze the data in real time using multiple forms of data noted here in this little purple box. So some debrief notes, training logs, study transition document, site observations, and then in-depth interviews with clinic and patients, staff. We see that in actuality, we had to wait until the end of active implementation, really into the start of sustainment, to start evaluating retrospectively what occurred using the frame IS kind of structure and forms to do so. So we did end up with a very comprehensive picture and still had all of that data, but being able to synthesize it using the tool was not as feasible. And so here is what the field team members completed in one instance with an example of modification to the audit and feedback strategy. So again, based on their responses, you see highlighted in yellow, they've gone through and indicated a few key changes. So there was a modification according to them in content and context. Fortunately for us, that context has an additional expansion box where they can further specify what types of changes were relative there. And there was an other box that they checked and then were able to write in a few additional details. But for the box like content, there really was nothing else indicated. So we don't know what changed in terms of the content. And they also clicked in module 3 that there was tailoring and that a drift occurred without returning back to the original implementation strategy. And so again, no further kind of details there. So if someone was not on the ground involved with conducting the trial and you were just to be looking at this form, it would be really hard to discern what was happening and really what the content changes were. And that's really what we're interested in here. So I think once we saw the forms, we were like, okay, we need to go back and get back into the data to see what's going on, because they were using, again, like I said, different forms of data to fill those out on an ongoing, or to collect that data on an ongoing basis, including the clinical debriefs, training logs, and site observations. And so what we ended up doing was kind of collecting all of that together with the field team and members of the study team involved with this process who weren't on the ground, and then trying to kind of attribute that within the frame IS form. And so let's do some comparisons. And you'll see here, there's some color variation because we didn't have full agreement in how the forms were created, because there was some debriefing notes that were summarized and provided to us that we then used to kind of complete the form to see would we complete it the same way based on the information that they were reporting as the corresponding summary. And so they gave us a few example summaries from their meetings, and then this is just one that I completed. We had another team member who was involved in this process. And right off the bat, there was a number of ways just in how we described the evidence-based practice and the strategy itself. The modification and the reason for modification were a bit different, mostly because they were thinking about it from a programmatic implementation standpoint, and I was thinking about it from the implementation outcome standpoint. So the language there was different, but the data stays the same. We did agree on terms of the content and context, both being modified, but how it was described in module 3 was different. So I had indicated a couple different boxes, only one of which overlapped with the field team member who completed the form originally. And so that was a kind of point of discussion, again, to unpack what their understanding of those terms were. And there was a lot of things that they just didn't think about when they were clicking the box. So the fact that instead of doing it monthly, they ended up doing it nearly every 2 weeks for most of the period of time. They hadn't thought about that as a shortening or condensing of the pacing. And then removing elements in terms of who was considered in that audit and feedback pool of data. And so it was just, what level of granularity did we want captured there and where those differences emerged. Interestingly, we see that as well with instances where they wrote something that I didn't write. And in that case, they actually had written in basically the same information that was in module one box. So that was easy to kind of disregard because we already had that data captured. But looking at personnel, I think one of the important things to note was we had a lot of study staff supported help for the trial that wasn't intended to be that way. And so thinking about what that means for certainly the sustainability was important in this trial. So a lot of interesting things came out of that process, and I think many, many lessons learned, given this was everyone's first time engaging with the tool. So just, at a glance, some lessons learned. I think, we would have had an entirely different experience perhaps if we'd thought about a way of making this an electronic data capture form. We steered away from that just due to issues of feasibility that were identified by the local team. And in retrospect, perhaps it would have been worth shifting and trying an electronic form that would have skip pattern features that would allow for more flexibility. Like I said, if you have more than one strategy being adapted, how you would notate those changes more readily without having 5 different forms on you for each of those. Having a different training process, so troubleshooting in a variety of ways to help elicit some of those challenges early on that we could then think about, adapting the form itself prior to use for our study, and then how to best integrate that into the workflow at these clinics, especially in terms of how and when data are integrated, because we did have multiple forms of data. And some of the more useful tidbits actually came out of the post-evaluation interviews with clinical staff and managers. And so, if you were relying purely on real-time data, you would certainly have a different perspective and missing some key elements, specifically as it related to that leadership structure dynamic. So what are you losing if you don't have some sort of inclusion of that retrospective evaluation data? But likewise, you limit yourself to the ability to then enact some of the lessons learned during the trial itself. So perhaps being more reactive and responsive to areas where you see drift occurring, or even kind of rolling out novel features and innovations that emerge that you didn't plan that could be beneficial to more than one site. Ways which we had seen in the literature FrameIS being used. We, of course, had looked to see, well, how are others doing this in the published work? And a lot of it was more as a coding structure. And I think I could see now, having used it, where people maybe arrived at that, because certainly we ended up using the tool, but I think it was a more of a retrospective framework in which we took all of the data we had, triangulated it, and are now working to kind of code it according to those categories and constructs so that we can better describe in a narrative fashion what changed and the impact of those changes. And so as we know, context matters, and in implementation, that's often what we're talking about. It's what we're interested to learn about. And here's a picture from one of our clinics that had a really nice layout of their files. You may have seen in the previous slide, some of the text summaries related to that audit and feedback form were related to the availability of files in many of the sites. So they ended up changing whose files they were pulling just out of the feasibility. They're like, we could be spending our whole lives tracking down some of these files. So we have to limit, the consideration of what patients are included in order to ensure that we're able to pull the data and provide audit and feedback accurately to the providers. And so we see this kind of ripple effect happening. Not every site looked like this, but if we think about the leadership stability again in this condition in this example, there's some typical conditions that I think are relevant as we think about context. So normally you would have a facility manager that's in place for a more long-term period. Anywhere from 3 to over 10 years would be standard for some of these settings. Other clinic staff may be rotating within the year or more frequently, depending on need and other openings. But this tends to be a pretty stable leadership structure under the best conditions, though you can see transfers happening due to vacancies and potential restructuring at the district level. What is atypical, perhaps, is everything we experienced in this trial. We started during the pre-implementation process with a bang. So we had the start of the COVID-19 pandemic, which changed everything in terms of our protocol and practices. But we also had a very extreme period of civil unrest and rioting within the local area of our sites that really affected safety and to a degree the ability to conduct some of the work and for people to be present in person. And then just to sandwich out everything towards the end of our sustainment, we had the, of course, termination of many USAID funded projects, which created a whole structural change in that way. And so we can't ignore the fact that, leadership is going to be affected by these higher level sort of societal issues that are happening. And so for the pandemic, we saw a lot of temporary redeployments as new responsibilities and needs emerged in the public health realm. And as a result, on an ongoing basis of some of the stress and demands related to these positions, it's not surprising that we start to see very high turnover and I'm sure burnout related to these roles. With the more recent USAID pullout, we had some immediate restructuring that was taking place. And then, of course, you have the roles and responsibilities being redistributed in line with that. And so there's certain prioritization of needs and ways in which these larger kind of changes, again, have ripples that are being sent out and affecting other contextual factors like leadership stability. And so it's interesting to think about while we can clearly track from our post implementation interviews that leadership stability is important in driving some of that mechanism operation from our logic model. If you weren't to scan out a little bit further, you might say like, well, what's driving it? And at different points of time, we see some different key drivers that may be responsible for that. But if we're only able to capture so much information, we may be kind of not zooming out enough and, it's really kind of dependent then for us to determine what we need to consider in those. Because as we've just spent the last 30 minutes-ish talking about just one of these strategies in some facet of one form that was filled out, there are so many other forms just related to this audit and feedback mechanism that we were tracking, changes that occurred over implementation and sustainment. And we had 5 other strategies. So we start to think about, what is feasible to monitor and what's the most important thing to capture if we're focusing on fewer strategies themselves and how they link to different implementation outcomes. And for us, I think that's even more challenging. And I think why we included them all was because there's a lot of interrelationship between these, where if you change the recording system for how data is captured, then obviously the audit and feedback is going to in turn change in terms of what we're capable of sharing back to the providers and managers themselves. And as a result of any of those gaps that we see, we may need different types of training and support in an ongoing manner. And who's providing that but the clinic champions we've identified. So I think, by and large, most of our strategies were really intertwined, and you start to kind of question how a change in one could then affect implementation within another. So here I'm a visual person, so I think this pretty much captured how I felt at the end of this process, that you have one change you're interested in looking at and it creates all of these ripples that are then affecting our various strategies and how we implement the evidence-based practice we're looking at. And if you're lucky, you're only looking at one, but we so rarely are. So then you have these interesting questions again of, where is that ripple coming from? And Do you want to zoom in and just focus on that base level change of it's the change in leadership that's the important context, or is it something greater than that and looking at these funding structures and pandemics and other things that may be happening that could be rippling down and having different temporality effects in terms of these contextual factors and how that kind of then again ripples across our studies. So I will wrap up there and just say thank you to all of the people who participated in this work. And like I said, it's ongoing as we do our final outcome papers and continue to move forward there. And thanks for our funders at the NIH for supporting this work. So I'll leave my email there should people have other follow-up questions that we don't get to in this time, but otherwise open it up to questions that may have emerged or to get back to the behavior change wheel.
Thanks so much, Leslie. That was fantastic. Just a couple editorial comments from me, and then I think we've had some good ones. I'm going to try and paraphrase or have people come off mute. I think we've got at least one or two great questions or comments on both the Frame IS, particularly the survey, and then one about the behavior change wheel, which I think will be really fun. And I wish we had another hour to talk about them. But just in terms of quick editorial comment, I want to say this is one of the most comprehensive applications and transparently reported applications that I've seen of both of those. So I congratulate you on that. I think so many lessons learned that you shared some of there. And the second thing is, I just have to comment. I think I've always dealt with, and I always like to say the issue about context is it always does change, and I think aligned with that. But I have to say, I thought I've had a lot of contextual changes, but I don't know I've ever seen the combination of as many major contextual changes as you just described to us. Let's maybe start with the Frame IS. We can go backwards then to the Combi. Gretchen had a couple good comments. I think started with ones about the use of this in a survey and maybe having some people on the ground rather than research staff complete the survey too. And if she wants to, ask her to, if she's in a place where she can come off mute to ask that. But it sounds like me, I've usually seen that coded, by a research person rather than a survey. But let me see, Gretchen, if you want to elaborate a little more on that.
Thanks so much. Thank you so much for the talk, Dr. Johnson. And I just was curious, sort of going back to the basics about operationalizing Frame into survey form. So what type of survey software was used? And did you gather, did you track the adaptations across any specific time points? And if there were adaptations at one site, was there a lag in communicating them to other sites? I'm just curious about just general operationalization. Thank you.
Sure. So for the Frame IS, we didn't have an electronic version of that. So I think that was one of the kind of lessons learned. If we went back, we might try to do that so it had more functionality and flexibility as a tool. We used it as a one-page printout. So exactly that form I had on the screen where it had the boxes and the modules that we had narrowed down. So it'd be one page printed. And we had people in the field that were intended to be filling it out. So they had kind of regular timeframes in which they would be going to the facilities to do kind of data quality checks and meet with the clinic staff and do debriefs. And the intention was to use that form at that time and collect that data. But as we saw in practice, they were still having the conversations, but they weren't then kind of transferring that data into the forms because of some of the early on technical issues and the burden of competing responsibilities in light of all of those other contextual factors that ended up really coming into play for us in this trial, unfortunately. And so I think what we ended up doing was taking that data and at the end, kind of backing it into the form and seeing, could we use it? Like, what would that have looked like in practice had we had a chance to do that? And that's where we saw a lot of the diverging interpretations of, what these different constructs mean as it applies to our specific implementation strategies. So I think even if they had filled it out, we probably would have had a lot of, variability in the quality of data. But now we have an opportunity to kind of use this as a methodological learning curve, hopefully, and to share some of that with others like yourselves and see how other people are using it. Because now I'm very curious how others have dealt with this because, yeah, I've only seen it used as a way to code the data. And we did have different interviews as well that was not intended solely to focus on adaptation, but really just, how did people feel about their experience at the end? Was it feasible? Was it appropriate where those adaptations were made? And how did that change their engagement with it? There was a lot to discuss in those end-line surveys based on everything that was happening in the setting, but hopefully that provides a little context. There was no explicit survey with this one.
Super. Such a rich issue. If I could just quickly follow up on the point about looking at the congruence and lack of which, and where you had congruence from different sources or different people there. I'm intrigued with that. And again, with this notion of transparent reporting, I've seen that seldom. I was intrigued with that. I'm also wondering, thinking about potential for different modalities that we get in terms of like mixed methods of assessment there. And you'd mentioned a couple times observations, and I'm wondering if those fit what your experience was with those, and if those also or how they entered in to the frame IS coding your understanding.
Yeah, I'm a big supporter of mixed methods research evaluation because I think we often, miss some important threads by focusing on one method over the other. And they're so complementary, of course, but the most interesting data and questions arise out of those areas where I see you don't have agreement. At least I think so, because then you have a lot of follow-up questions and really great team discussions. And so I think for us using the frame tool where you saw that kind of intercoder reliability, if you will, it was more of interpretation of the tool, not once we discussed the actual issue, we were all in agreement of what was happening, but how they described it and transposed that into the form was very different how I would do it. And I think a
Mhm.
limitation of that we found was just because of the summary data I was looking at did not include their observational data from the clinic. It was limited to what they chose to write down. So as someone who was not present, I didn't benefit from the richness of that data. And so we've been working since then to kind of capture in a more Excel document all the various forms of data so that we have a very rich data set to pull that information into the forms and to be able to understand each of the modifications with that full picture in mind. So that's our hope.
Yeah, super. Thank you. I'm just watching chat. I think we maybe have time for one more question about the experiences with the Frame S itself, and then I would like to turn to the Combi, just primarily because I think that's a little newer for this particular group than some others. But are there people can either quickly enter into chat, or if you want to, we can be brief, take yourself off of mute too, if there's anything else about the Frame IS, either application or results that people would like to query or share their experience.
I see Lydia's used FrameIS to document. I'm curious to hear your experience, Lydia.
Yeah.
Hi. Oh, I'm quickly moving rooms because there's someone in a meeting there. So I loved your presentation. Thank you very much. I used FrameIS throughout my PhD. First, doing scoping review about nurturing care interventions. So I mapped how these interventions adapt during COVID. And after that, there's a program here in Brazil that it's also a nurturing care intervention. And then I mapped with, I compared with the publications from the national government, so the recommendation that they did during COVID and what happened and what happened actually with the interviews and everything. So it was really nice, I think, useful. I did the coding as you described it. It's a nice way to describe. So I found one implementation adaptation or implementation strategy, and using the modules from FrameIS, I described it how this adaptation came up during COVID. It was a nice experience, but I'm interested in started understanding and studying a little bit about more about COM-B. So that's really nice if you can talk a little bit more about it. Thank you.
Yeah, absolutely. Yeah, it's interesting to hear. I think definitely for something where it's more abstraction and using other data sources, again, with the coding process, it seems a bit easier. I'm still grappling with the real-time use of these types of tool, and I've taken these lessons learned, and I'm trying to currently use it to accomplish the same goal for another trial. So we'll see how well that fares out, I guess, with this new approach. But in terms of the behavior change wheel, it's a very comprehensive process for us. I think, 6 to 12 months in total of engaging with our different stakeholder groups and, in parallel, collecting the data that we were bringing to them at these working group meetings to kind of provide a lay summary overview of the process and get their input and feedback at strategic points. And so across each of the phases, you have a different goal. And that first one is really kind of that needs assessment, figuring out what target behavior are you changing. And so for us, it was, clear in some degree that you have a nurse in the clinics and you want them to take the blood pressure at every clinical encounter. What gets a bit complicated, of course, for us is that we were trying to change the care cascade. And so you effectively are having like multiple COM-B assessments because every time you have a new person with a new behavior, you have a new quandary to unpack. And so that's my word of warning to those who have not used this, if you will, that just pick one behavior. So we had a couple different that we were looking at. And so we tried to kind of combine those, and we had interviews and focus groups planned with patients, providers, clinic facility managers to understand the determinants of behavior that we identified. And then we reported that data back to our community advisory group. Ideally, this would have been sequential where we finished all the formative data and had that kind of nicely packaged to then parcel out with them and complete the process. But due to COVID and a lot of the like social distancing issues that were rapidly put into place, we just modified and went with it. We did it in parallel. And our kind of stopgap was at a certain point, we didn't have all the data collected, but we'd collected enough data. We just decided to do the first working group opening with an activity where they could identify any barriers they felt like were not captured so that it was a comprehensive set for them to consider. And we had them rank them according to priority. And then there was some discussion around feasibility because our clinicians were like, of course, we want to hire new people. We don't have enough HR support, but we don't have additional money to throw out this issue. So what is the next best thing? And role differentiation became kind of the parallel feasible aspect. And so each of our 3 working groups reviewed the data that was relevant to them. So the clinicians looked at the clinical level data, patients, the patient level data, and then our lucky community advisory group that was more wide reaching had to look at all of them. So they met twice. And they all came to us with 3, or as it were in the last group, more than 3 barriers that we completed across like one table where at least we had patients and providers equally represented in terms of priority targets. And so at that point is when we had it narrowed down. We then did a survey to kind of look at those appease criteria. So how cost effective is this? How, does it drive equity issues? And we had our scientific advisory board, who is external to the study, actually give us that Likert scale feedback to rate these and help us kind of, we didn't use that as a sole criteria score to select them, but it was a piece of the picture again saying, okay, well, now let's take this back to our community managers and see, well, we can't put TBs with educational material because the TB there has been broken. They're not going to fix it. So we can scratch that off the list. So we kind of worked through this iterative process, taking the advisory board feedback. So they helped us, define that mode of delivery, go back to the clinics and see what's feasible for them, and then score it with our scientific advisory group based on what the perceived value and effectiveness was largely. And from those selected things that could be packaged well together. So even if it wasn't a top scoring strategy, there was something embedded in there that we could, like a low hanging fruit, attach, and they would be complementary. And so that was a lot of the thought process there. But it was a very complex process to depict, I can tell you, based on my reviewer experience with the manuscript, but it will be out soon. So I can promise you, if you want to read more, you can check that out in the Translational Behavioral Medicine Journal.
Thanks so much. We'll look forward to that. I also appreciate your describing the back and forth, the process with your advisory board. That's intriguing. I had maybe we'll close with the last question. Showay had a question early on about the combi. To her and my understanding, was originally developed at the individual level. But you've applied it. I think I've just seen one or two, not an expert in it, applying it more at a larger implementation science level. So I'm just wondering about how well you felt that worked and any thoughts you might have about applying it at a different level.
Yeah, I think that's why I caution with really being particular about the way you're using it and having a key actor and behavior that person is doing that is the focus and application of that process. We took that mapping process and used it best we could to identify implementation strategies, knowing that it wasn't going to be a perfect fit. And it was
Mm.
largely this translation issue of like, okay, well, when they say mode of delivery here, what is that to us? And like their term for mechanism versus how we're using it. But I think by and well, it worked. We were able to have a very systematic and rigorous approach, which I appreciated. But I think it was the complexity of considering all of the determinants according to each person at that level. Because even though we're thinking about how to create system change with these strategies, they're based on determinants at the individual and clinician level. And so really you're kind of orbiting all of those queries around those individuals to start off that process. And so I think that's where the link is to using this as an individual level kind of data driver to then think about the system. But they do have the outer, or I think they're calling it now the behavior change sphere because they've added so many new layers and now it's 3D. I'm not quite certain, but a part of that outer shell is the policy implication. So I think, it's designed to be used in a versatile way and kind of fold in whatever layers make sense. We just didn't end up using that component of it, but we did dig in, and I have a separate publication that focuses on mapping the theoretical domains framework
Mhm.
constructs onto the COMBI model and giving us more granularity in terms of those determinants. So also available if you're looking for extra reading. Happy to share those with this group.
Fantastic. I'm sure there'd be a lot of hunger. I'd love to see those. If you don't mind sharing those with
Yeah,
Kara, then we can send those back out or distribute them. Thank you so much. We're at time here, but again, great congratulations. A super job, I
thank
think, of
you.
a systematic, comprehensive application to a really challenging situation and things. So we really appreciate your time and thanks all of you for attending and your questions. Hope to see you next month.
Thanks, everyone. Bye.